So next, we have a topic that is near and dear to so many of your hearts here, whether you are a clinician, a scientist, or a healthcare professional, and that's building the next generation of healthcare workers. And we've already seen so much promise and potential of AI in helping that next generation, whether it's helping doctors be more prepared for visits, supporting diagnostic decisions, or automating documentation. And that's why at Innovaccer, we are so focused on these provider productivity tools because they really serve a dual benefit. They, one, let our clinicians practice at the top of their license by really reducing that cognitive burden. And two, they ultimately increase access to care by increasing the capacity that every single provider has. So with that, I'd love to introduce our Chief Innovation Officer, Dr. Anil Jain, and our esteemed panelists to talk about how they are deploying these technologies and thinking about these technologies in their organization.
Okay, well, I'm Anil Jain. I am the Chief Innovation Officer at Innovaccer. A bit of my background before I introduce Dr. Han. I'm a clinical informaticist, an internal medicine doc, and I've been dealing with innovation between AI and clinical medicine for my career. We are joined by Michael Han, who is the CMIO at Multicare Health System, and he's going to give us a little bit more background on himself in a little bit, and then we will be joined soon by one of our other colleagues, and I'll introduce him when he comes. But let me start by asking Michael a question. Tell us a little bit more about your personal narrative, how you came to be interested in AI, and more importantly, how you're thinking about AI for your healthcare organization. We're really focused on thinking about how AI can be used to leverage some of the challenges we're all having in the AI workforce. So maybe we can go ahead and spend a little bit of time in doing that. But I see David is here now. So maybe what I'll do is very quickly introduce David and let you all know that he is the EVP of UC Health at the University of California. And he can also go through some additional background in a few minutes. But maybe, Michael, you can tell us a little bit about yourself. Tell us a little bit about how you arrived at focusing on AI as part of your job and your journey.
Sure. So my name is Michael Han. I am a urologist by background. And I think that my generation, and I'm also a clinical informaticist, and I refer to my generation and Neil's generation, our generation of informaticists as accidental informaticists. I don't think that we ever dreamed while we were in medical school or in residency that we would be an informaticist or a medical information officer or what have you. It was we grew up during the time of meaningful use and implementation of electronic health records after the HITECH Act, and those of us that had a little bit of background in computer science and understood logic and could call BS on the analysts that were implementing the electronic health record got voluntold to help lead the push from a physician standpoint. I think that a lot of the pain points that physicians, providers across the American healthcare system have felt over the last 15 years since the HITECH Act, actually it's more than 15 years now, were due to promises that we made regarding electronic health record that weren't necessarily fulfilled. And now with everything that's been going on over the last couple of years with large language models, artificial intelligence, and machine learning, I think we're finally going to be able to fulfill some of the promises that were made with the initial implementation of electronic health records. And so I think this is a super exciting time for all of us in healthcare technology. And so I'm going to leave it at that.
So before we have David introduce himself, I do want to make sure you explain to the audience, what is a CMIO? Because it's shifted around a little.
Yeah, so as the Chief Medical Information Officer for Multicare, it is, I think that at the very beginning, it was to make sure that we achieved meaningful use. I mean, I think that was pretty clear at the beginning of the teens. Now, I think that it evolved into how do we optimize the electronic health record, and how do we make sure that physicians and providers are using the electronic health record to the top of their capabilities. And now I'm hopeful that it moves from a more stable, like creating stability for physicians to innovation and disruption in the especially with artificial intelligence and the new technologies that we're going to see in the next couple of years.
So David, tell us a little bit about your journey and your background and how you came about being interested in AI, and especially thinking through the workforce side of things.
Yeah, thank you for having me here. I guess I'll start out and let everyone know I trained actually at UCSF back in the 90s under my current boss, who was the Dean of Admissions, President Michael Drake, who's also a physician, and spent my career up until about 18 months ago out at the University of Pennsylvania and at the Children's Hospital of Philadelphia. I'm a pediatrician by training, where I directed a public policy center and actually helped develop a population health management program for a health system that has about 700,000 children and adolescents crossing the threshold every day. And during that time, as being responsible for the population health management program, very systems oriented, and there's been a huge emphasis in terms of excess demand on how we manage patients, particularly in the ambulatory environment, and particularly moving away from the traditional office visit to how we provide more convenient care away from the office. And that ultimately involves distributed workflows. It's not solely the responsibility of the physician. In the context of a growing electronic health record and responsibilities to that EHR, the real question at the point of care is how we distribute a workflow across a team that might include, beyond the physician, nurses, medical assistants, schedulers, et cetera, and optimizing the investments we've made in EHR to do that. You know, as I return now to the University of California as the EVP of Health for a system that sees 11 million outpatient visits a year and 1.3 million inpatient visits, and touches people from 91% of the zip codes in the state of California. That vision is very much alive. The burden in terms of excess demand and trying to keep up with how many people want to come to the University of California for our care is greater than ever. And so these distributed workflows have become preeminently important, and the role of AI, and particularly agents, in terms of helping to distribute that workflow, to make it easier to communicate digitally with our patients, and with growing challenges fiscally, even now in the federal environment, you know, figuring out how to do more with less, I think is accelerating the timeline around AI interventions, both to relieve cognitive burden, but also to help distribute workflow in a more efficient way.
Thanks, David. Now, you brought up a few different things. Just, you know, one of the main questions I get whenever I go to a cocktail party is that someone will tell me that they've been waiting 3 months to see a primary care doc or 6 months to see a specialist. And in David, you alluded to a few areas around the use of AI to help improve capacity. Michael, what is Multicare doing to help improve the capacity to try to get more patients in, given I'm sure the stories that I'm hearing are the same stories you're all hearing about the capacity and the wait lists and all that. So how's your organization approaching this?
Right. I mean, I have the same story, right? My primary care doc retired at the beginning of this year, and I called for a new primary care provider, and without pulling strings, and I didn't pull strings, I still haven't seen a primary care provider, and I'll see one in June. So it's.
You want to see one in Cleveland? I know a good one.
So, you know, I think that the first sort of AI really, I think that everyone understands the people, right? We need to hire more people, right? And so we have moved forward with more APPs, advanced practice practitioners, so PAs and nurse practitioners in a sort of team-based environment, paired up with primary care docs in order to improve access. I think that's the people part, right? I think that the process, there's the process as well, in terms of how do we triage the people, how do we triage patients who are calling in for a primary care visit? How do we understand who it is that needs to come to the front of the line, especially from a value-based care standpoint? And then it's the technology, right? And so I think that one of the first, we'll call it AI-enabled technologies that we implemented that we thought would improve access was ambient clinical documentation. So, we're fairly early in our trial. We've been on a particular solution for the last year now. And while we've seen a decrease in documentation time and a slight decrease in time in chart, we have not seen an organic increase in number of patients seen. I know that there are other institutions out there that have seen an increase in the number of patients being seen, and that throughput exists. I think that the other area where I have a particular interest, and this is probably more of it's driven by my own personal narrative, in that when I first came into practice as a urologist 20 years ago, it typically took me about 6 patients. I'd have to see 6 patients in my ambulatory clinic in order to book 1 surgery. By the time I stopped seeing patients in 2021, I would go and see 25 patients and not book 1 surgery. And so the access issue is a real issue, and a lot of it has to do with referrals that are incomplete, referrals that are done because primary care docs just don't have the time to actually care for the patients. And so how do you work upstream to provide other sorts of care, be it virtual, asynchronous, what have you, in order to open up access? Because we know that early access leads to early diagnosis, which leads to early treatment and early cure and reduction in the overall cost of care. And so, those are the things that we're doing right now in terms of looking at how to use technology, but we have to put the people and process in front of it.
It's a very good observation. And for those in the room who are innovators and are thinking about ambient, there's a great study from the Peterson Technologies Group where they did a meta-analysis and looked at the pros and cons of ambient. Would encourage all of you to go reflect on that. But you brought up a few things, Michael, around physician extenders, nurse practitioners, perhaps increasing sort of the capacity that one might have, not only in primary care, but maybe even in specialty care, where there's a significant increase in the number of physician extenders that might be seeing patients even for specialty care. So David, when we were talking in preparation for this panel, you were kind of alluding to some of the ways that we can help, using AI, help some of these physician extenders, helping support some of the nurse practitioners and physician assistants, really thinking through the next generation of the workforce that might be keeping all of us healthy. How are you approaching this within the UC Health system in order to use AI to upskill all the folks that might be seeing the patients in the future?
Well, we have 5 and now 6 campuses as the University of California, Riverside continues to grow, all of which are their own innovation ecosystems, developing work around AI. I applaud, we actually have an enterprise data warehouse to train AI models as well too, and a shout out to Dr. Atul Butte, who was the founder of that group. So there's a tremendous amount of work going on across the system, and I sort of divide that work to recognize that the goal at the core element of our work, this is still a human business. And so the goal is not to replace the people or the eye contact. In fact, when you actually talk to frontline providers, whether they're APPs or whether they're physicians, we're trying to restore eye contact, right? And so stuff like scribes have been tremendously valuable and well received by our frontline, and we're doing a lot of work around the use of AI in terms of scribes. But then as you get into these extenders, you really are talking about this triage, right? Which is the excess demand we're seeing in our specialty care offices, particularly in the state of California, where it's very hard to retain primary care physicians. AI can really help augment the knowledge base and the ability to create these sort of constructs by which you would move through a diagnosis into a treatment plan and potentially reduce burden on some of our specialty care providers if we can do more through our extenders in the office. And then it becomes, how do you create decision nodes of what you can take care of locally or through virtual care versus what actually has to be referred into Dr. Han's office.
Oh, that's fantastic. So what we chatted about so far is really thinking through how do we make sure we're putting in the right AI tooling in order for physician extenders to take care of the increased number of patients that want to be seen. We talked about how we might also try to increase the capacity just by doing better triaging. Now, one of the things that I recall vividly in my career, having implemented the 4-letter EMR in at least 2 different systems, one is that we might inadvertently create a digital divide. There might be some patients who are quick to embrace a patient portal and others who may not even have a smartphone. That's changing these days, obviously, but how do we make sure that when we think about a digital front door for all our patients, that we don't inadvertently create a new digital divide where those who are savvy with AI, those who adopt what AI is doing for them, those who think about a new way of engaging with the health system, either asynchronously or synchronously, that we don't leave an entire generation of patients behind, those who might need this technology the most. And maybe, David, you can comment, and then we can go to Mike.
You know, I'll even back it up in terms of what our health systems are capable of. You know, it's on both sides. And so if you talk to a typical CIO who has an Epic system, right, they've barely scratched the surface of what Epic can do. I spent a lot of time working with the software in population health management that builds registries and reports to help distribute workflow. As by the time I had left the Children's Hospital, 85% of our patients were flowing through registries in those workflows. You go to most health systems around the country, they barely know what Healthy Planet is. They're making big investments in third-party sort of overlays with dashboards for population health. And the truth is there's a really important workflow that reduces cognitive burden, actually makes it easier to deliver care at the front office. So the first thing I would say is, when I started this journey, CHOP was reticent. What is this all going to mean? By the time we finished that journey, they had spun out a company, WellConnects, that is delivering these professional services on how to implement these services. Now, as we move beyond the basic registries and the workflows, what I think is good about what Scribe has done is it hasn't removed the intermediary, which is the physician, to say, do I agree with the advice that my patient is being offered? And what that means is when Scribe looks at an inbox message, or an inbox query about how to give a patient advice when the patient calls, it recommends a response. But the message to the patient will first say, from an ethical perspective, that this was generated by AI, but then, quote, comma, edited by Dr. So-and-so. And that allows the doctor some facility to understand their patients. Now, if we extrapolate that to our patients, only a third of our patients actually uses MyChart, which is the interoperability, right? So you're getting at the sort of literacy. But most folks have cell phones, right? Everyone knows how to receive a text. But in the same context, if an AI agent is actually using information to triage an individual to schedule an appointment for a procedure or a follow-up, one of the things we can build into that is the knowledge that not everyone's going to know how to do that. And you can offer people a link to do it themselves, or the option to press 2 that says, would you like to talk to someone who's a live voice? And I think I'd be happy just to get to that, because that kind of addresses the question you're saying, which is how do you keep this usable and how do you avoid disparities developing from people who can access this? Yeah. Right? No, that's really insightful. I think a lot of us who end up getting the robocalls of yesterday don't really continue those calls. But this is a new generation of having AI engage with patients in which their current experience is pretty abysmal. And so there's an opportunity there. Michael, any thoughts on this?
Yeah, so I think, one way that Multicare is trying to address the digital divide is through our Connect program. And so where we provide IT services to critical access hospitals, federally qualified health centers, to make sure that they are actually implementing the best and the most secure technology. want to double click on something that David said in terms of meeting patients where they're at, right? We absolutely have to meet patients where they're at. And whether that is, phone, God, I hope fax goes away, but phone and text message and clinical communication, secure clinical communications, all of those things are going to be what enables us to implement nice things like hospital at home, aging in place, as we face the silver tsunami that's coming our way. Yesterday we had to ask Gemini what the average age of the population here in the United States was, as compared to the Republic of Korea and Japan. Japan is up clear, close to 48. Korea is at 45, and the United States is at 38, and our birth rates aren't getting better. And so the challenge of taking care of elderly populations is just going to get worse in the developed world, and we need technology in order to address that.
So now, David, you heard Conrad and Brian and Aparna talk a little bit about the use of AI in pop health and how they're approaching it. Anything you want to add in terms of thinking through where can AI help us transition from doing the right thing for the right patient, the individual patient at the right place, to thinking about it at a population level? Any insights that you have from your experience? I know you built some insights when you were at CHOP, and then you have some additional ones now.
Well, if I take any one of our health systems in California and I overlay that to the current financial environment that we're all facing, cutbacks to Medicaid, Medicare, challenges in terms of labor expense and rising costs of supplies and pharmaceuticals, everyone's trying to do more with less. And so now you extrapolate that out to a front office that would normally have 5 people. And I think we have to have the honest conversation that going from 5 to 4 people and introducing AI agents to basically triage and distribute workflow and directly push out messages around refills or scheduling of patients or scheduling for annual procedures, or even as simple as here are all of our colonoscopy results from the region and who actually gets triaged into emergent scheduling. There are a lot of workflows there that actually are going to make it easier for us to do more with less, so that the folks who are going to be in the office, the APPs, the nurses, the physicians, et cetera, can spend more time just focusing on the patients. And building that capability in, to me, is where I think a lot of the innovation is going to be over the next few years in population health, is how to perfect those agents in a way that it reduces cognitive burden and helps patients at the same time, right?
Yeah, I want to double click on something that Aparna said earlier today in the payvider space. I sat down with an AI vendor a couple of months ago, and they showed me a lot of technology that they had developed in order to ease patients' ways in terms of referrals and prior authorization. And I asked them point blank, I said, well, wait a second. So are you working with the payers too? So you're creating bots on the provider side and you're creating bots on the payer side. And so now you're going to have these bots go to war with each other over prior authorizations. What Aparna has really touched on is the important, that's not value added work for anybody. And what Aparna has really touched on is that why not get rid of that prior authorization process and have an understanding across a partnership or collaboration between providers and payers, without having to raise armies of agents on either side to duke it out, because that's what we're doing right now. And so anything that we can do to improve the collaboration between payer and provider or payviders is going to be important, because none of us can take on any more work.
So I call that the arms race, by the way. Yeah. It's been very profitable, but honestly, it serves no value to the actual patients and their relationships with their physicians. But to me, the quicker we can move towards agents and their relationship to the actual delivery of care and the doctor-patient or the nursing-patient relationship, the better off we're going to be as a society.
We do have to be careful. There are a few innovators in the room here who are working on prior auth innovation, so we just have to be a little careful.
It's a necessary evil, I get it.
That's right.
I mean,
So what? Yeah, yeah. One of the things that, Michael, you said this earlier on when you were introducing yourself, that we were accidental informaticists. We were at the right place at the right time when we were implementing all this new technology that clinicians in general didn't really know how to best leverage. We're at that same inflection point around AI and generative AI. The number one question I get is, what is a co-pilot? What is an agent? So how do we think about the workforce and educating them about these AI principles and getting, even at the medical school level, or even prior to medical school, when they're still doing their pre-med courses, making sure they're ready for the new workforce where they'll be partnered with AI instead of partnered by themselves? Like, how do you think through that?
Yeah, I think that training and education on any digital tool and continuing education is really important. I think it should be part of, and I've made this point to my CMO, that it should be part of medical staff credentialing. It should be part of ongoing certification. We have to educate our workforce on this.
So in Ohio, where I live and am licensed, I have to take at least 4 hours of CME for opioid management. Are you suggesting I take 4 hours of AI education?
I think not just AI, but overall utilization of electronic health record. The electronic health record and AI, they're tools. They're no different than, I met somebody from Intuitive Surgical earlier today. They're no different from using the Da Vinci robot. You have to prove that you're proficient in using the Da Vinci robot. The electronic health record is no different. And so I do think that, and I probably know how to use 15% of Excel, right? And that's probably okay for me, maybe 10%, right? I mean, but if I only know how to use 15% of electronic health record that is so central to how we deliver healthcare in this day and age, that's dangerous. And so I think that it's just as important as opioid education, and it should be mandated at least at the, maybe not at the state level, but certainly at a health system level.
Are you guys going to mandate it at UC Health? You going to mandate?
I think the responsible and ethical use of AI in terms of your clinical care is sort of where you're going. And I think the training is more around that, and the guardrails around, this is still a human, I started out my comments saying this is still a human profession. I think there was a lot there, when we initially started this journey, a lot of suspicion. What do you mean AI is going to tell me how to take care of my patients? But the truth is, the moment you start talking to your friend Chat, you realize there's a lot of information. There's a cognitive value to kind of challenging your own assumptions about the care you're providing. But at the end of the day, I think it's in that intersection of how we use those tools and understanding the literacy of our patients and the recognition of our unique value as providers to be an interplay with the information that's being provided from AI, and then how you actually treat your patient and inform the delivery of their care in their home with their family and all the other challenges that they're facing. And so I do believe our education, the tools themselves, if we do them correctly or implement them correctly, should be easier, right? I don't find the interface that if you ask a question about a particular disease, diagnosis, or treatment, like that's easy to pick up over time. So I think there's an innate ability to develop these tools in a way where it's actually easy for the providers to interact. It's much more challenging to think about where they insert in the workflow and make sure that it's actually clinically effective for their patients.
So Innovaccer is a proud member of the Coalition for Health AI. And one of the strong programs that CHI is promoting is the ability to put what we call model cards in front of clinicians as AI is being used to help support their care. But when I talk to clinicians, and maybe even I think I feel the same way, is that reading all the details around how the model works that typical machine learning data scientists or AI engineers have developed might be overkill during the clinical process, and clinicians expect their leaders to have vetted, they expect, for example, Michael to have vetted that before something gets implemented at Multicare Health. When you think about responsible AI and you think about the workforce, there's also the side of, do physicians understand probability? Do they understand possibility? Do they understand some of the differences between a deep learning model and a neural network model? At what level do clinicians need transparency in order to sort of go with it? Like most of my colleagues who are internal medicine docs don't know how an MRI machine works. Yet we order MRIs way too often, right? So any thoughts on that before we transition to the very last question?
I don't know. You know, my perspective is sort of like your 15% analogy on Excel. I'm not sure most physicians in their busy lives that need to get too deep into the what, but they need to understand the limitations, right? And also, to me, that's the key part, to not over-rely on it, but also see it as a potential tool that can reduce your cognitive burden and help improve your efficiency in your day, and honestly, your joy of actually caring for your patients, right?
Yeah, I mean, I think it's incumbent on us as informatics technology leaders to vet the products as much as possible. Again, you know, frontline physicians aren't involved in purchase of an MRI machine, right? Unless maybe you're the radiologist, right? I mean, frontline surgeons probably are involved in purchasing a Da Vinci robot, right? I mean, they go out there and they certainly try and push that. I do think there's a certain basal level of education that you're going to have to provide on these tools, but the ins and outs and the drift and what have you, I think that's probably a little bit too technical for most physicians. But I do think that some basal level of education and training is necessary in order to safely use these tools.
And certainly the surveys done of patients don't indicate that patients want their physicians to be experts on AI by any stretch. It's really about the limitations and about the use cases in which the AI is being used and the disclaimers that you mentioned earlier. So transitioning to the last question here before we take maybe a question from the audience. When you think about the folks in the room, innovators, healthcare leaders, other industry partners, what bit of advice would you have for them about AI investment? If you could maybe spend a minute, each of you, on just your words of wisdom around thinking about getting into the AI front.
I think in my experience in population health management, I've seen a lot of solutions that were top-down, that played more to the executives than they did to the average physician, medical assistant, scheduler in a front office. And we have found in my career that the improvement models really are grassroots, they're bottom up. If you really want your product to be impactful, it's going to serve the cognitive burden or the throughput challenges that your office down the street, whether it's a urology office or a primary care office, the pain points that they feel, and it's going to make their lives easier and make their jobs more rewarding. And so I would encourage the developers, as they do their focus groups, to spend more time looking at the actually outcomes and processes and the experience of the people who are right at the point of delivering the care.
I couldn't have said it better. I mean, for me, it's about the people and the process. You cannot forget that this is still a human, that we still need humans in the loop, that we need to teach the people, we need to train the people, and we need to have good process, because you can't automate chaos. And if you don't have the process locked down, if you don't have the definitions that you need, you're only going to turbocharge or supercharge a really bad process that's already getting bad outcomes. And so, don't forget about the people in the process, because technology doesn't serve as a forcing function in healthcare.
With that, what I heard was we don't want to automate chaos. We still need humans, thank God. We still need humans. And I think our patients expect that there still be humans in the loop in a significant way. But I hope you would both agree that there are some tasks, some low-value tasks that we should fully automate or eliminate, going back to the prior auth example. I do want to give the audience maybe a minute. I'm not sure how much time we have. I can't see anyone in the audience.
We can do one question.
One question, okay. And if you could announce where you're from as well when you ask the question, that would be helpful for context.
Yeah. So thank you so much for the amazing panel. I am Deepak Subramanian. I'm representing a company called Kinkor Health, as well as I'm a recent graduate from University of Illinois Champaign-Urbana. So we are specialized in AI. So what do you think about the future of remote patient monitoring or chronic care management? So which is also in the, try to focus on the preventive care management. So how do you think such programs are actually helping the current system? And if you want to improve, what are the key pointers you would give us for young entrepreneurs like us?
I think it's a terrific area for innovation. We're seeing excess demand in our own hospitals. Our EDs are overcrowded, helping. So that's sort of like direct-to-patient care and family care. I mean, there's a part of that element which is the relationship between the hub, the provider, or the health system, and the families who are caring for their family members at home. There's also an element of remote patient monitoring is helping that individual, that family member, to know when to call or when to reach out or when to actually go to the emergency department. And I think it's much more proximal to that decision-making. If you implement remote monitoring with the data that you can have there, we can actually do more with less and actually provide true value for the healthcare system as a whole, right?
Yeah, I mean, I think that RPM is a huge space. I mean, I touched on the silver tsunami, hospital at home. I mean, all of that's going to be a significant part of it, and we need to continue to double down on those technologies. We also need AI to sit in front of the data in order for physicians not to have to sit there and sort through to try and find the signal from the noise. And so I think that it's a great area to be in.
Yeah, I think AI plus RPM plus the reimbursement models that are out there are a game changer. So with that, I do want to thank David, you and Michael for a wonderful conversation. I think you guys will be around for a little bit as well. If there are any questions that you all have that we didn't get to, feel free to ask. But thank you so much.
Nice meeting you guys.